So thank you all for coming to this speaker session at the Global Summit to End Pandemics. Franklin Apfel has had a very important role during this pandemic in working on public communication. There's a long history of public health efforts, and I have been told many remarkable things about his work. I don't want to take the time here, but please look up his record. Um, uh, Franklin, please take it away and tell us about communication in a pandemic. Thank you.
Great. Well, thank you very much, and thank you for inviting me to join here. And I've really been appreciating your this network's existence, uh, and see it as a really a major and strong force for enhancing our communication capacities on all levels in terms of this COVID pandemic. Uh, just a few thoughts to share. I mean, I think we could all accept or we all acknowledge the fact that COVID, if nothing else, communication from the margins to the mainstream. I think we all understand it, or like the world understands it more as a clear determinant of health, and all the discussions we've had about the infodemic and the issues related to communication have certainly been a major force in terms of uh, the realities of health in all our different environments. What I'd like to focus on is really the role of the World Health Network in this communication marketplace that we're existing in. And in essence, really, I think the mediator of the influence of communication is health literacy, and uh, we usually define health literacy as the capacity to obtain, interpret, understand health information and services, and the capacity, the competence and confidence to use that information to enhance health. And when we're talking about health literacy, we're not just talking about individuals' health literacy, or we're talking about individuals, but it's not just people receiving services, but also people providing services. So health literacy of professionals and providers, but also health literacy of policymakers. And we're not just talking about those individuals, we're also talking about the systems in which people are operating with. So we talk about health literacy a lot as a functional reality, and that the skills and abilities of people have to be matched to the demands and the tasks of the systems, and that many systems can make health literacy more friendly and easier for people. So let's bring this over to the World Health Network. I think that what I've been seeing in terms of already the outputs of the network is that it's evidence informed, it's very how to oriented, it's providing more accessible, understandable, adaptable, and usable information. And I think that really our challenge is to find a way collectively of being able to frame our messages or reframe them for more positive kinds of actions. Now, we have been engaged over this last 18 months in producing we meaning my organization and colleagues here at the World Health Communication Associates, have been involved in uh, producing a daily newsletter, which we call Connecting Communities. Um, and basically, this newsletter, which we talked to our community about prior to starting and asked them what they were looking for. They very strongly gave us the feedback that there was lots of communication about blaming and shaming, but there wasn't very much communication about how to deal with stuff in really practical ways. And that in particular, they focused on 8 topics that they thought they needed more how to information. Uh, some of that's already changed over time, but basically it was around isolation tips, people having how people are coping or protecting their health and mental health through lockdown realities, hygiene helpers, how people are keeping themselves and others safe from corona infection in different settings, community actions, what communities are doing, how you could work remotely in that reality, how virtual classrooms, how people were learning and training from home, public policies, how different countries and policies were working or not working, how countries or communities were maintaining essential services, and finally, stuff about healthcare and what innovations and interventions were coming down the pike. I think the World Health Network is very well placed to help in terms of communicating that kind of how-to information to target audiences on three levels: individuals and communities, people and policymakers, nations in terms of policymakers and institutions, and international agencies and multinationals. I already, and I think many of us have been inspired and informed by this. We'd like the exchange platforms and the innovation kind of activities of the network. We can make the case docs, the case studies, the kind of do-it-yourself school ventilation program, advocacy activities, all of which are stuff that we can relate to. So why and how can we really help with this framing and reframing? I'd like to suggest one particular approach here, that if we can build on our mission and values, so we have a clear mission and ethical values, we bring a unique frontline change agent perspective and experience to information marketplaces. And with this experience and information, we could add value of practical experience to inform action agendas on all levels, and we can help frame elimination messages. I would say a lot by positioning ourselves and framing ourselves as what I would call positive deviance. And that's the message I want to really deliver. I think that the organization is really a positive deviancy organization. Positive deviancy is a concept and a behavioral and social change approach first adopted by UNICEF many years ago, when they looked at communities that were in sort of starvation and in more difficult times. And there were some families or some mothers and children that survived in those areas. And they looked at those, what they were doing differently that allowed them to have successful behaviors and strategies. I think that as an organization, we could be positive deviants in the communication environment. We have this experience of people that have been able to thrive and survive in very difficult situations when all around them are maybe not doing as well. And I think that we can bring that to the health information marketplaces and be an important reframing force to help both individuals and communities that are having to survive and thrive, hopefully within environments that do not have good policies or really health promoting realities, but quite the contrary. And increasingly, we're seeing this in terms of our communities that are saying, like we're living in the UK at the moment, just, let it rip. It's all over. We're going to live with with COVID. And eventually, I hopefully sooner than later, we will need to go into some additional lockdowns and change that approach, as they're accepting too many deaths and too much suffering. We can be positive deviants in all this environment. And it's that thought that I wanted to share, and I end this short presentation with, in the sense of inviting us to reflect on how we can serve that role as communicators more broadly on all levels in terms of individuals and communities, also national governments in terms of our advocacy for change, but also international agencies that need input from frontline people to ensure that they maintain their role as international agencies and not get caught up as being intergovernmental agencies. With that, I'll close and open it to any questions and comments.
Great. Anthony, if you want to serve the role, you can call for questions and moderate about 5 minutes of questions.
Sure. And I'll just echo, well, I have a question myself. So according to those studies, primarily the one where UNICEF looked at the mothers that were thriving in those situations. So what were they actually, do you recall anything that they were actually doing or what strategies they were taking?
Yeah, in some of the original studies, it was just some of the way they were able to provide and ensure that the little bits of food that they were able to obtain, they were providing to the kids. They were making sure they were hydrated. They were also trying to maintain their activities and some of the same kind of strategies that we've been talking about of how people maintain their health in environments now through the COVID time, where actually health services are not really terribly well available to people for every other kind of problem. I know personally in our own family, we've been dealing with a variety of issues that have arrived through COVID time. And most of the stuff we've had to sort of do self-care with and find other kinds of information sources and resources that are different than the typical care and treatment facilities. I know that in the first issue of the newsletter from the World Health Network, they talked about some communities in India that were thriving in terms of at the same time that other communities were not doing as well. Yeah. So we're privy to some information and knowledge in regards to ways of helping to organize our schools to be safer, helping to organize our communities to be safer. Where we go, where we do our shopping, or how we spend our time. Whether we're, in the UK here, there's no requirement for anything, right? And so we pick our shops where they are still maintaining a mask requirement on the indoors. We don't go to the other shops. We try to reinforce that and promote those shops. We trying to set certain kind of standards, and I think that there's an enormous experience in terms of our collective knowledge as a network that we can provide some guidance to people in terms of those kinds of behavior changes.
Franklin, my question would be, if this is the mission, and I know this is a very big question, but maybe a short answer would be helpful. What would be the media that we should be using? I know you have developed a tremendous mailing list of people that you are sending out to. We want to complement what you are doing. What would you say to us? Focus on this effort, this project. What would it be?
Yeah, well, I think that we should certainly be looking to work through a variety of channels and a variety of platforms and stuff. We're currently engaged in a project supporting capacity development in 16 countries in Central Asia and Eastern Europe on enhancing their capacities around social listening. I think that's a big area that we should also be working in terms of social media and both how people are talking about the issues that we're particularly concerned about, and how we can be more effective in our communications in those areas. So yeah, I think that we should be players in the social media community, and I'm sure there's a variety of our members that are quite active on a variety of different platforms in that space. So we could be working with them in that space. I think we should be working with journalists. One of the things that our newsletter, which basically aggregates stories from around the world on a daily basis. We usually overnight we're downloading some 300 or 400 articles in these 8 different areas that I mentioned. We then look through those in the early morning, and we send out a newsletter with 30 to 50 stories with short summaries that then people can link to those stories. What we've developed through that over these 18 months is a huge database of journalists who are writing about these issues in these different specific areas. So I think we could target those journalists as well in terms of stories in particular, and that would be I think quite a useful kind of activity, so that that they can reflect some of the approaches that are being described here. The other activity that we've been involved in, which I think is also quite fits in answering this question, is that we have a little group that meets on Sunday nights called the Secret Sage Group. We call ourselves, right? But there's 2 or 3 of the people have quite a large media presence in terms of being interviewees at mostly television shows in the UK, but also quite a few in European countries and extending into India and into some African channels as well. So what we've been using those opportunities is to sort of prep these spokespeople to deliver messages in terms of topical issues of the week and stuff. So I think that's another role that we can play in terms of some of our spokespeople within the network, prepping them to be providing some useful information in terms of responding to topical issues.
Outstanding. Anthony, I want to move the session forward a little bit. Khalid was supposed to speak here. I saw him here in this room in the previous hour, and I thought that he was here just early and was sort of participating in the Q&A there. But my guess is that because of the time change, he may have thought that was the right time for his presentation. So if that's the case, maybe we should assume that he is not going to be here. Oh, Khalid, you're here.
Yeah,
actually. Are here. Ah, perfect.
Yeah, I thought that I will be presenting at 16 hours. That's why.
But very good. I'm glad you're here. So why don't we move ahead to Khalid's talk? I'm very pleased that you're here. So Franklin, I will displace you down here. Oh, I'm doing it in the wrong way. Thank you very much. Very good ideas, and I would like to talk with you about them a lot more. We'll have opportunity to do so soon. Khalid, if you were to drag yourself up to the place where Franklin was, there we are. Khalid is a public health expert and working in PAR. And I think it will be extremely important for us to hear about how things have gone there and to learn from their experience. Please
yeah, thank you very much for this opportunity, and I would like to thank the World Health Network for having me here. I have a presentation, but I don't know how it will be uploaded. I asked Sharon to upload the presentation, so I'm not sure if that's possible.
if you have a presentation to share, I will help with it, but I need to get it. So why don't you start talking and I will find out.
Okay, I send it to Sharon. Yeah.
I will call.
I'm here representing actually myself. I'm not representing the Qatar government or my organization. I'm just here reflecting on experience that I was part of it about Qatar experience in COVID pandemic. As you can see from the data that you see from all over the world, that Qatar right now relatively they have very low numbers of positive cases. It's usually between 100 to 120 cases per day. 50% of the cases usually they are coming from abroad. So what happened? Similarly to other countries, Qatar had the first wave in March. Cases start to accumulate by March 2020. After the declaration, of course, of as pandemic, WHO declared COVID as a pandemic. And cases started to accumulate until mid of March. We had the first wave, and there was a lots of measures that have been taken by the government. Qatar population is around 2.7 million. It's not a big population, but still there are so many efforts have been done in that country. Specifically throughout the pandemic, the goal of Qatar is to reduce the rate of transmission of infection and the number of deaths associated with COVID, while at the same time maintaining the provision of vital healthcare services, as all countries are doing. Several steps have been taken early into the pandemic in form of non-pharmaceutical public health measures, such as closing schools early, limiting the capacity of workplace to 20%, everybody work from home, and also closing workforce. The first case in Qatar came actually from Iran, and after that the cases started to accumulate very fast. Although at that time there was closing border with China when the case from Wuhan was there. So in the 29th February, Qatar's first case was reported, and 8th of March, a travel ban on specific countries have been introduced. And 10th of March, schools and transport were closed. The whole country was locked down on 10th of March. On 17th of March, no foreign visitors. On 18th of March, there were only 20% people working from their workplace. And 21st of April 2020, only grocery shopping and pharmacies were open. Everything else is closed, gym, salon, everything, even restaurants. Nothing, only grocery and pharmacies and hospital, of course. On 22nd of March, mask wearing was mandatory by the government. So you cannot go any place without wearing your mask. And I will come back to the mask wearing, because I think this is one of the things that we need to address it here to understand how can we go with the pandemic. As you know, right now, 2/3 of the cases right now from Europe, from the whole cases of COVID in the world, the 2/3 of the cases are coming from Europe. And this is, we need to question that. Why is this happening with the mass vaccination that's running right now in all these countries? On 26th of May, mandatory installation, there was also the using of technology. Actually, one of the things that I think that was very successful in Qatar is using technology with COVID. There was an app, it's called Zahtaraz app. So this app, it have to be installed for every single person in that country. And usually that app will be green if you don't have any symptoms. Once you have any symptoms, it will be shifted after the confirmation. It will be shifted to yellow. If it is confirmed that you have COVID, it will shift to red. And if it is red, you have to. In the start of the pandemic, everybody was quarantined by the government. So you would have to have, even if you have a very slight symptoms, you have to have in a governmental institution, a hospital or a facility, quarantine facility for the government. This quarantine facility was very comfortable. So it was.
Khalid, I have your presentation, but I think you're presenting it really well without it. I would go without it. I think it's much better this way. Please go ahead.
not that just visual for people. But as I said, again, for the technology, using technology during COVID. So this app, as I said, that every single person in the country have to have that app. And if you want to go to grocery, you have to show the security guard there that you are green, so you can enter the grocery. If you don't have it, if you're yellow or red, you cannot enter the grocery, and you have to order everything online. Lastly, creation. Just right now, Franklin is talking about communication, risk communication. I think the creation of helpline. There was helpline that 24/7 for suspected cases, for people what to do, for anybody have any symptoms, for anybody that you want to report anything. So there was a continuous communication between the government. So the call center, which is the 16,000, so it's an additional way to support the population and responding to queries and concern. And it was a dedicated phone number was created. This helped to identify suspected cases and directed patients for testing and assessment by the dedicated medical teams. This comprehensive multi-phased approach also served to prevent and mitigate an overwhelming demand towards our health services and hospitals, so that priority could be given to COVID patients, particularly who are suffering from complication. Also, there was a very robust contact tracing and random sampling. So there was a lot of contact tracing for any positive case, and also a lots of surveys and random sampling. So there was, as I said at that time, the border was closed. So all the sampling, random sampling was inside the country where they feel that there is a hotspot in any side, that they will go there and randomly sample. Qatar population, as they said, 2.7 million, but they are testing between 20,000 to 30,000 per day. So a lots of testing have been conducted. Early in into the pandemic, a team of contact tracers were created by Ministry of Public Health. A positive case were found. Guidelines were established by Ministry of Public Health. Random sampling helped in further isolate positive asymptomatic cases. So there was an early detection for asymptomatic cases, not only symptomatic cases. After that, they divided the timeline in the country for 4 phases. So first phase, second phase, third phase, and fourth phase. The first phase started on 15th of June 2020 by partial reopening of mosques. Once they found that they have some control measures and they can start to be down. They start to reopen malls and parks. But still they kept the workplace in 20%. Phase 2 started on 1st of July 2020, and this they increased the employee number to 50%. And phase 3 started on 1st of August with full reopening of shopping mall. And phase 4, permission to host large gathering such as businesses. There was also a lot of work have been done with Qatar Airways. And for example, if you are coming to the country, what needed before you come. And in the airport itself, if you are not vaccinated, you will be swabbed. It's not up to you. If you are not vaccinated, you will be swabbed in the airport. So this is part of the... One of the impressive things that quarantine, as I said, quarantine facility was cared by the government itself. So if you are asymptomatic, but still you are positive case, you have to be in quarantine. In the first, the government was providing these quarantines. So they took all the hotels in the country and they converted them to quarantines. So if you are asymptomatic, positive case, you will be in that hotel. You will have a very nice room. Your food will be there for three meals a day, whatever you need. But the only thing that you cannot get out from the room, you cannot get out from that room if you are asymptomatic. If you are symptomatic, it depends on your situation, and then definitely you will go to the hospital where you will be provided what needed. And then the Minister of Public Health, then the vaccine came, and the vaccine came in 23rd. So the vaccination program, mass vaccination program, started 23rd of December 2020. And they used only messenger RNA vaccine. So they used only Pfizer and Moderna. Other vaccine wasn't used in Qatar at that stage. I can say that majority of people in Qatar, they have been vaccinated only by messenger RNA vaccine. There was mass vaccination campaign, and right now I think they vaccinated more than 2 million from the population with 2 doses. With the 2 doses, and only the rest is coming right now. Maybe more than that, even more than 2 million. And also, they somehow they related the vaccine with the app, the Ihtaraz app, the one that I said that it will be green. So with the vaccine, you will have like a golden frame. So it's that you are green, you don't have any symptoms, and also you have a golden frame that you are fully vaccinated. And by this, you can enter malls. So without it, you cannot. So if you are not fully vaccinated, you will not be allowed to enter any public place. Lastly, I want to speak about mask wearing. I think I am right now. I am here in UK, and I can see that although there is mass vaccination programs running in the country, but still, when you go on the streets, you see that many people, they are not combining with a mask, and even you can enter any place without mask. I think even with the vaccination, with a high number of vaccine, even if you have vaccinated everybody, I think mask wearing should be there. Big question with schools: what to do, what age? All schools, not all schools. This is another big dilemma that we have to think about. And yesterday I heard a lot about ventilation, improving our ventilation system, and here it reminded me about cholera cases in the past, and John Snow, the father of epidemiology, when he discovered the cholera in London. And from that date, it was in 18th century, and we took one century or 100 years to make sure that we have a good water and sanitation system in the country. I think similarly, it will happen to our ventilation system. The first flu pandemic, we should say the Hispanic pandemic, or the one that happened in 1914. So from that time until now, we have done lots of improvement in ventilation, but we have to do more to make sure it's not only about COVID, it's also about influenza and other respiratory diseases that can evolve. And we have mentioned about evolving all the time. So this is what I want to say. Now the further steps that Qatar is taking, so administering the booster dose, they are giving whoever received the 2 vaccine, that he will be receiving the 3rd vaccine. And me personally, I received 3 shots from Pfizer vaccine. I received the first one, second one, and the 3rd one. I already received it as a healthcare worker. Mandatory face covering indoors, malls, public transport, it have to be. There are, until now, it have been used, and that's why we see a very few number in Qatar. And also joining vaccination campaign of COVID with the national influenza vaccination campaign. So you will have the influenza vaccine and the COVID vaccine to prepare yourself for this winter. And also, as Frank was speaking about communication and making sure that you have a helpline to receive all the calls that needed from anybody that inquire. We're looking for eradication. And whenever it comes to eradicating this COVID, I don't think that we can eradicate it totally. As COVID, I think that he will be with us as the virus for a very long time. But we can eliminate it as much as possible with the vaccination. Hopefully also with the discovery of new medicine to treat it. By that, we can eliminate COVID to very small cases. So this is what I have, and thank you very much.
Thank you. Khalid, can you take a couple of questions?
Yes, please.
Anthony, please call for questions. I will hop out and in a moment.
Okay. Yeah, does anyone have any questions? I can't think of any right now.
It sounds like you've done an admirable job of keeping the situation under control there.
Yeah. As I said, it's maximum. It's 100 cases per day, and 50% of them usually are coming from outside the country. So inside the country, the local transmission is only 50 cases. And usually these 50 cases among unvaccinated, so usually among below 12. But right now they started a mass vaccination program from 5 to 12, and hopefully that all schools will be vaccinated. Vaccine are available, so it's just about vaccine. We know that vaccine is effective. Nobody have a doubt. As I said, me myself, I took 3 doses of the Pfizer vaccine. I didn't have any side effects. Except the normal one, which is pain in the site of the injection, a little bit fever in that day, and that's it. So I think vaccination is very, very important. Making sure that you have mass vaccination. Vaccine have to be afforded to anybody who need it. Start from high risk group to anybody in the community.
When you talk, go ahead.
Yeah, could you reflect on the sort of the sense of equity across the whole population, and was this available to all the foreign workers in Qatar as well?
Thank you. Very good question. So actually, in Qatar, the population actually divided to 2. We have like 1.2 million is like we call them craft manual workers. Or single male workers, which are the majority of the country. As you know, that Qatar is booming. There are lots of infrastructure there is building up and preparing for 2022, the World Cup. So the whole country is under big revolution of construction. So that need a massive army of single worker to work there. So there were also a part of that. When I say it's more than 2.2 million have been vaccinated, it's include craft manual worker. Actually, they have been provided vaccine. They have done for them a very big mass vaccination center, and through their companies, the company are obliged to bring them and vaccinate them. In the same way, if anybody from these workers are sick, his company should make sure that he will be isolated in a good facility.
Thank you.
I have a similar question. You said 50% of the cases are from outside the country. Are those identified when they're in quarantine? And so are the 50% from outside? Are they basically limited from the population before they're diagnosed?
Yeah, actually, as Qatar, as other countries have been classifying other countries to red list, green list, that we are hearing all the time about it. So if you are coming from a red list country, you have to be tested. You have to provide that you have been tested there, but still in the country, still again, you will be tested again. So even if you have a PCR, negative PCR, and you came to the airport with a negative PCR, you will be tested in the country if you are coming from a red list country, unless you are vaccinated or fully vaccinated. This is the only exception.
Okay, so my question is, those 50% are controlled. In other words, they don't spread within the country.
No, yes. From there, once you are positive, as I said, you will be directed to a quarantine facility run by the government. You will not go to your house and isolate yourself in your house. No, you will be diverted to a quarantine facility run by the government, but you have to pay for it, of course.
Just a comment. I was looking at your numbers on one of the website, and it looks excellent, and the method looks excellent too. So, congratulations.
Thank you. Yeah. Actually, it's not my effort. It's actually the government. When it comes to control of diseases, elimination, eradication, all these definitions that we in public health we're using, it's only about political will. If there is a political will, it will happen. So if you need the government to understand, to support the Minister of Public Health or NHS or whatever, or Public Health England, whoever controlling that, you need the support. If there is no support, everything will fall down.
Yeah. We've seen a lot of examples of the fall down part.
Exactly. Exactly, yes.
Thank you.
Thank you.
You did say you are going to vaccinate from 5 years.
Roger, I apologize, but the time is going, and I'm going to have to ask. Anthony, with your permission, we will let Wendy go next because she has a issue where she is and she may be kicked out. So if that's okay with you, we will let her go next.
Thank you
Sounds
very
good.
much.
Let me move Khalid back. Wendy, could you drag yourself to where Khalid was? Are you going to do a projection, or you are?
I'm going to do a presentation, and I hope I should be able to share
Go
it
ahead.
myself.
Why don't you share your screen and let's see
Yeah.
how it goes. It should
will.
allow you to do that.
Okay, so hopefully you see my screen share now.
Not yet. Could you try again? Because it didn't come
Yeah,
up.
let me try again. Share. Okay, can we see anything now?
No, we don't see the screen projection, and I do not know why it would be creating problems.
It says here, oh yay, is sharing your screen.
I do not see it, unfortunately. Let me try to do it myself for a moment. Can everyone see this? You can see mine, correct?
Yes.
Correct.
Okay, so it's not oh yay, so please try again. That, by the way, was the Qatar dynamics that has been doing well.
Okay, what should I?
Try again, click on the share, and then make sure the window that you're choosing is the window you want to share.
Okay.
Share your full screen.
Yeah, let me try again. Sorry. So
there we go.
Right.
Now we have it. Yeah. So please go ahead and choose the window you want to share now.
Stop. Okay, are you able to see it now?
You can see your screen. Now why don't you share the presentation?
Yeah, I will.
There, yes, we can see it.
Okay, so I'm a teacher from Sweden, chemical engineer, and I would just like to explain what's going on in Sweden. I'd really like to talk about what's been happening in Swedish schools every day, but also that our health authority has been doing a lot of misinformation. They've been very, very anti-masks, even all the way from the start. So much so that they actually presented this video a few months ago, that the way we were supposed to protect our elderly was to hold our breath. So this is an official health authority video of how we should help our elderly.
Tack till dig som har visat omtanke om andra. Fortsätt kämpa hela vägen fram.
So what they're saying there is, thank you for holding your breath and helping the aged to protect them from COVID-19. And this is one of the biggest problems that we have in Sweden, that there is just so much information, disinformation and misinformation that's being sent by our own health authority. We're all very familiar with the Swiss cheese model. If we want to stop the COVID virus from getting to the masked user over here, then there is a certain number of procedures we have to follow. One of them, of course, keep your distance. We are also told to stay at home if you're unwell. We're told to test yourself if you have symptoms, but usually children under 10 are not able to get tested in Sweden. We always hear, with the World Health Network to wear a mask, but that's never been recommended in Sweden except for rush hour on trains and buses for a short period of time in Sweden, but it was not well adhered to, and more than half the population probably didn't wear a mask even if they were in buses on rush hour. We've been told to vaccinate ourselves. They've only just started allowing 12 plus age group to be vaccinated. The health authority made this decision 6 weeks ago, but that's only supposed to be implemented at the beginning of November. So everything we do, it seems to be, delaying. And this is your personal responsibility to also reduce your contacts, but they've even taken that away now. So in Sweden, we have absolutely no mitigations whatsoever. Not only that, but they've said that after the 1st of November, Vaccinated people, even if they have COVID symptoms, are not allowed to test themselves and not allowed to get tested. So we know that you still can catch COVID and give COVID to other people, and you're not allowed to test yourselves anymore. So we are going to be in the situation where we really don't know what's going on. What are schools supposed to do then? What's the school's responsibility to try and reduce COVID? Well, they're supposed to do a risk analysis. A few schools have done it, but they're very lacking. They're supposed to try and reduce the infection level. The only way we've got of reducing infection level is a bit of alcohol gel in the classroom. If they have a breakout in the school, they're supposed to eliminate those risks and redo a risk analysis. That is not happening in almost any school in Sweden. Breakouts happen and they're just carrying on before with just alcohol gel in the classroom. They're also supposed to report the infection risk to the health authority. None of the schools that we've spoken to or had contacts with are actually reporting this infection risk at all. So they have no idea of what sort of level of breakout they're getting in the schools. And they're supposed to then improve their risk analysis and go back, and this is supposed to be a loop, and it's actually not happening. So has Sweden actually aimed to protect children and staff from COVID in schools? In spring 2020, our health authority guy, Anders Tegnell, he wrote an email saying herd immunity was the Swedish strategy, although both Tegnell and the government have repeatedly denied this. They can't deny the emails that Tegnell has sent. He also had an email saying, keeping schools open will help Sweden get herd immunity faster. And he also wrote in another email that 10% of pensioners might be worth it. So this is the background here. Tegnell has obviously been trying to use schools to spread COVID-19. How have they helped prevent spread in schools then? When a child going into a shopping centre had to have at least a minimum of 10 square metres per child, but there was absolutely no minimum in school. 30 pupils in an overcrowded classroom has been totally acceptable. COVID-sick families up until December 2020 were expected to send any symptom-free kids to school, which was basically a denial of both pre-symptomatic and asymptomatic spread by children. So they had to send their children to school, even if they didn't have any symptoms. Even risk families were forced to send their kids to school. So you could have had multi-sick children or multi-sick siblings, and your other children still had to go to school. There was no preventative measures for them, which could basically be a death sentence for one of your children. Mask wearing in schools has repeatedly been told to us it's totally unnecessary, and Anders Tegnell has even said it could increase the risk of infection if we actually did wear masks. So here we go, time and time again, our health authority is sending misinformation. They published a report initially saying that there was absolutely no increased risk to teachers' health. The second report that came out, they said there was no higher risk to teachers compared with other health workers, now admitting that there was an increased risk for teachers, but no higher than doctors and nurses. The Corona Commission came out with a report last week showing that teachers were at very high risk. We had 70% of our outbreaks in December 2020 actually originated from schools, and this was really, big in the media. So our health authority, the Folkhälsomyndigheten, actually enforced that schools should stop measuring the outbreak. So they stopped publishing all school data, just like an ostrich sticking your head in the sand. What you're not measuring, you have no idea where you are. And people in Sweden laughed when Trump said, well, if we don't measure what we wouldn't have any COVID. And people in Sweden laughed at how ridiculous that statement was. And then they actually started doing the same thing ourselves with our health authority, and there's no outcry from the population of Sweden. The health authority's mantra the whole time was that kids don't get seriously ill, kids don't infect others, natural infection is better than vaccination, and COVID is definitely not spread by aerosols. So this is what we've been up against in Sweden, in schools. And my question is, and I think a lot of us in Sweden that are with World Health Network really question whether the health authority is actually using children to spread COVID in the community, and by denying them protection in school, by pretending that masks don't help, when we all know that they actually do. So I thought I would let you know what we've actually been doing. What preventative measures have we had in a Swedish school? Well, basically only alcohol in the classroom. That's the only measure that we've had. We've had no mask recommendations for staff or pupil. We have actually sacked staff and for wanting to wear a mask. Children were suspended from school for wearing a mask to school, and some municipalities banned masks. There was a big media discussion on this where a lot of those municipalities had to back down afterwards, but that this situation could even come up just shows you how extreme the masking situation was in Sweden. There was no bi-weekly or any screening, testing, tracing kits at all in school. So they weren't really accepting pre-symptomatic and asymptomatic spread. No carbon dioxide measurement in the classroom, no class bubbles, 1,000 pupils changing class every hour. In my school, 3 different stories. There's only one main stairwell. All the kids were running between the floors, 1,000 kids crossing paths every hour. There's no filtration measures to reduce virus spread in the classroom at all. No HEPA filters, no ultraviolet ways of reducing it. No minimum distance in the classrooms or in the corridors. And we have compulsory schools were not closed at all, except for a few weeks after Christmas for the older children aged 13 to 16. And the health and safety law to report the risk of infection was basically flouted by pretty much all schools, and I've looked at the data there. So following the health authorities' recommendations, it seemed that the schools thought it was much more important to follow the health authorities' recommendations than actually follow the law, because the law about you should always be safe at your place of work and risk analysis have to be done is written into the law, but that was flouted by most of the schools. They just thought they had to follow the health authorities' recommendations, which were not legally binding. We've had a lot of problems with disinformation in Sweden as well. The problem was that UK and Sweden both went for a herd immunity policy in the beginning. So here you can see, if you look at the daily rates in 2020, they are very low for both. Sweden is the bright purple one and the brown one is UK. For both Sweden and UK, because we were not actually measuring how many people had COVID. But if you look here in the same period, the death rate in wave 1 was enormously high for both Sweden and UK. Then we actually started measuring in UK and Sweden. You can see that we continued to have a much higher death rate than all of our counterparts in Denmark and Norway, the other countries in Scandinavia. So this herd immunity policy has had a detrimental effect on Sweden. People are talking now that in Sweden we've got a fairly low infection rate. And the question is it really low, or are we just testing too little? If you look here, United Kingdom and Denmark are testing about 15 people per 1,000, whereas Sweden down here is testing 2 or 3 people per 1,000. So does Sweden really have a low level, or is it just like last time due to the fact that we're not testing very many people? Other sorts of misinformation have come from our own Swedish state-provided television, because what they do is whenever they're presenting the case or the number of cases in Sweden, you'll see that they put such an enormous high y-axis. Don't do it relative to the population and always have Sweden incredibly low. Whereas here they're comparing it with the UK, where they're putting an axis which is showing really, really high levels for the UK. But this isn't relative to the population. So if you look at this graph that I've got here to the left, this shows that at the time that this TV show was presenting, Sweden was in a much worse situation than UK. We actually had an almost identical situation and infection level to the UK. So the misinformation is going through our media channels as well, our state-paid television. Here are some of the quotes that Tegnell has given us over the years. If we start looking back here in February 2020, he's sort of said, or our health authority and our government prime minister, coronavirus will not spread to Sweden. We're very well prepared, even though they had very little protective measures and very little PPE. They said back in March, we've reached the peak. It will peak on Tuesday. We're going to have herd immunity by April. We're going to have it by June. We've flattened the curve. We're going to have herd immunity by June again. Tegnell praising the idea of UK's herd immunity. They decided herd immunity. Sweden has peaked and infection rates are going down. And this was our curve all the way through. Swedish Prime Minister says that Sweden made the right choice going for herd immunity. Our assessment appeared to be correct. Very cocky here in July and August of 2020, denying that we were going to have anything like a third wave. They were worried about, they published that we don't need to worry about Sweden now. The ones we've got to worry about are Norway. Here is Norway's final level of infection. And then suddenly we had this massive wave here where they denied we're not going to have a second wave. And then suddenly everything was out of control. So this is how our old health authorities have been misinforming us. Yes?
Yeah, I don't know how much longer you're planning, but you should wrap up within a minute.
Okay. You can see here our children have a very high level of infections. And if we look at countries, we can see that 11 times more Swedes than Norwegians have actually died from COVID in the older areas. But even in Sweden, we've said it's only the younger people or the older people that have died of COVID. But here we can see all age groups have much, much higher death rates than our Scandinavia counterparts. And they're really the only ones that we can compare with, because all of the other European countries are much higher population densities than Sweden. There's one more example of misinformation that I'd just like to briefly take, Janir, and that is that Finnish schools were compared with Swedish schools, and the European Centre for Disease Control in the European Union actually quoted this report that was made by the Swedish Health Authority. And if we look here at the number of reported cases, it does look very similar between Sweden and Finland. The problem was that Finland actually tested every child with a symptom, whereas Sweden only tested anybody who was admitted to hospital. So we had one Finnish child actually admitted to ICU during this test period, whereas 14 Swedish children were admitted to ICU. So the infection level was 14 times higher for the Swedish people. So this is what we're sort of fighting against in Sweden and have been trying to work against and for and with, to make sure that, you know, it's very difficult to know what to do. We are a number of people trying to work in Sweden against the misinformation, but we've been really struggling. We've been working with the politicians. We've been trying to get somebody to listen to us, but basically it's turn up to work, stop complaining, and don't do anything. I'd really like to thank Maria Torlund for her great slides that she helped to contribute to me. And I'd love to take some questions about any ideas or thoughts you have of our situation in Sweden.
Thank you. Let's just take one or two very short questions. Who has a question, please?
I'll ask a question. I just say, are there any positive deviants in Sweden? Are there any private schools that possibly have done things a little differently that could be an example of another option? Or
we don't really have private schools in Sweden that are paid for by the parents. We do have some state-run private schools that have had masks in school, but it's been very, very little. I'm in a comprehensive of 1,000 pupils and staff. I'm the only one who's worn a mask for the whole year. Basically, nobody else is masking up at all. We've had very high level of infections. 6 of my 9 colleagues, closest 9 colleagues, have all had COVID and all been given it by the schools, and still they're not wearing masks. So what we have in Sweden is we have this very conformist society, whereas if the government tells you to jump, you sort of ask how high. And many of us that are questioning and fighting against this policy Many of us are actually foreigners, although not all of us. I mean, there are a number of Swedes as well, but we're definitely in the minority, and we definitely have a lot of people against us. Mentioning or discussing my opinions of Sweden's COVID policy in my place of work is totally taboo. And just my activity outside of my workplace, it can also be affecting my career potential. But I have to anyway, because it's so important.
Thank you. Is there one other question that people would like to ask first?
There was going to be some commissions that were going to actually investigate Tegnell and his activity. Has it happened?
The Commission hasn't investigated Tegnell yet, although they have said that they came with this Part 2 report now, and the Part 3 will be coming later next year. But they actually called the Commission, the whole coronavirus strategy in Sweden, pretty much an abomination. They said that it was very late, very unprepared, and very badly taken out. Our Prime Minister has gone into retirement, and the head of the health authority has been sacked, but he's been replaced by somebody who's just seems to be carrying on with exactly the same policy that we've had before. I don't think we're going to see a change in policy. I mean, as I told you, even vaccinated people are not even allowed to get tested from this month.
So you mean Tegnell got sacked?
No, Tegnell didn't get sacked. Tegnell's boss, Johan Carlson.
Okay.
But Tegnell is expected to retire in the next couple of months. So all the people that have propagated this policy, they're just going to disappear out of the system instead of being held accountable for what they've done.
Yeah, Tegnell has killed 10,000 Swedes, actually, compared even accounting for the population differences. Because if you counted Finland and Norway together, then 10,000 old Swedes have died completely in vain because of him. So it's mass murder, actually.
Yeah, we've actually looked at, my presentation was a little bit longer, but we actually looked at the cases of Miss-C amongst children, you know, the multi-inflammatory syndrome. And Sweden has 5 times the number of cases per capita of children that have suffered from the multi-inflammatory syndrome. So opening schools and having absolutely no mitigations, no protective measures has come at a price, and the government seems to be doing more to actually just push down on and push back, not give us the right information so that people are not able to make a good choice. They just want to keep schools open so parents continue to go to work, and they've definitely prioritized, in my opinion anyway, the economy over Swedish lives, and it's come at a great cost.
Wendy, thank you for a very strong presentation, and obviously we are with you in your battles, and we hope that things will finally find a better path forward, and there will be some accountability. Thank you. I'm going to take you off of the speaker's chair. Anthony, do you want to move yourself there and let me know if you are going to project or you're just going to talk? What is your preference? You are muted though.
Sorry, I'd like to project, and I think I'll do that now.
Okay, let me
window
in share mode.
Long COVID. Okay, so can you? It might have a bit of a lag, but can you see this?
Yes, we can.
Okay, excellent.
You can go in the presentation mode. And I just want to introduce Anthony. Anthony has demonstrated an ability over the pandemic to be one of the clear voices of reason. I just have been informed that there is a huge campaign in Germany that has evolved out of a letter he wrote. They're talking about it in the next room over, but let's hear Anthony and his description here. Thank you, Anthony.
Thank you, Dr. Barham. Okay, so I'm just going to talk about long COVID, and I'm going to do so from an immunologist perspective, because we're getting a lot of kind of misinformation and downplaying about long COVID and kind of implications that it's purely psychological or anxiety. And that kind of started before, before we had much data too. So it was almost like there was an intentional skewing. So, okay, so long COVID. So it can span physiological systems. Patient experiences can be different from each other. So the most important thing to do right now, pretty much when there isn't much data, there's a lot of data now, but when we're still gathering information, it's great to listen to people, to listen to the patients. And so William Osler had a quote, "Listen to your patient, he is telling you the diagnosis." So I think one of the most important things to do is, instead of preempt everybody and say, oh, it's anxiety, oh, the psychological impact of COVID is great, but it can be overcome. Just before doing that, because it's disingenuous, just listen to the patients and listen and see what's going on. And part of the reason why COVID-19 can affect so many different physiological systems in long COVID is because of the expression of ACE2. ACE2 is the receptor, the protein that is used by the virus to enter cells. And so there's a nice review paper on all the different physiological systems that can be affected after, that can present with symptoms after COVID-19 infection and different symptoms. I think the biggest one was fatigue, and the next biggest one was headache. But it's a nice review. And so, as I was saying about the ACE2 expression, so it spans different tissues in the body. Many different tissues, many places in the body can be infected by the virus directly. Now, when the virus infects these cells, there is inflammation that happens in the organs that are infected. The immune system will go and kind of travel to these locations and then kill the infected cells. Okay, so it's not a great thing. It's kind of a trade-off when your immune system is killing infected cells, because usually you need those cells, for your normal physiology. But when you're killing them, obviously it's going to hurt you. So it's kind of a double-edged sword, the way the immune system clears the virus. And so it's many different locations in the body, that have the ACE2 receptor. So long COVID, there's a subset of long COVID that one group from Northwestern found called neuro-COVID. And what they saw was, it gets technical here, and I just took a quote, but they saw that the T cells kind of had a program or a phenotype that suggested that they were perpetually active and that they were quite exuberant. They easily produced high levels of interferon gamma in the people that had quote-unquote neuro-COVID compared to other long COVID types. And interferon gamma and the interferon family, so they're known, much of them, not the immunosuppressive one, but they're known for causing symptoms, like serious symptoms like fever and, just feeling terrible. So I know that when some people are given interferon as what used to be a hepatitis virus treatment regimen, one of the risks was that the people would eventually feel suicidal because it was so terrible to go through this treatment with interferon. So this group found that there were high levels of interferon produced by the T cells, and that the T cells were of a phenotype that suggested there was a chronic infection going on. So another avenue for chronic infection potentially in long COVID is this group found that monocytes and macrophages were being infected, and when they were infected, they were possibly replicating inside those cells. Normally, we thought that didn't really happen, that these cells weren't permissive to replication, but this group, presents compelling data that it does happen. Okay, and so another term for long COVID, post-acute sequelae of SARS-CoV-2 infection. So one group found that these people with PASC, another type of long COVID, they had low T cells that were against SARS-CoV-2. So what's happening there is they're drawing the blood and they're looking for T cells. So those T cells have probably migrated out to somewhere, like maybe the periphery or maybe immune privileged sites, maybe the eye, maybe the brain. We don't know. It would have to be investigated. But it's concerning, and I would think it's possibly what's called a functional depletion, whereas the T cells are, they've been called out somewhere, they're somewhere, but they're kind of depleted from the blood. So there's another paper that shows that dendritic cells are also lower in people that have had COVID-19. And the question is, well, where are they? Have they been killed, or have they migrated somewhere? Why aren't they being detected in the blood? So the one paper in the BMJ showed that there were elevated numbers of dendritic cells in the eyes. Normally, the eyes are immune privileged sites. You don't want inflammation there. In fact, the eyes will have expression of a gene called Fas ligand, which will intentionally kill immune cells if they ever, migrate into the eyes, because you certainly don't want inflammation there. And the eyes are also kind of an analog for the brain. They're both kind of immune privileged sites where you don't really get dendritic cells and T cells just going in there and causing inflammation. But in PASC people, there were increased dendritic cell numbers in the eye, and they also had inflammation in the optic nerve and around the optic nerve, some damage to the nerves. So it's possible that in long COVID and in neuro long COVID, these immune cells are migrating to what are typically immune privileged sites and causing inflammation. So the conclusion is we have a type of functional depletion of T cells. We have migration of dendritic cells and maybe other cells into immune privileged sites, and we might have a viral reservoir in some cells at a low level of replication. Okay, so that's the presentation. Thank you. And does anyone have any questions?
Yes.
Anthony, this is talked about a lot about whether there is or is not viable virus in the long COVID patients. Now, I know that there's been RNA found, but any studies where they've tested whether it's viable, whether they could reproduce virus from those tissues?
It doesn't look like they tested that per se, but we do know some other viruses can enter, RNA viruses can enter low replication cycles. And this isn't my theory, this is someone else's, that they think, some other viruses do this. But it's possible, it's persisting at a very low level. There are a few case reports, and there's one where a person had reactivation, and it was the same virus, and it was after they recovered, and they had, after some time, they had reactivation. It's reassuring to me that it's not very frequent, and it's not very frequent in places like Australia. From before, we weren't seeing a lot of reactivation, but I really am at a loss. I don't know. Yeah, it's a good question.
Franklin, did you have a question? You came on.
Yeah, hold on. Yes. Can you reflect on whether a vaccine seems to affect the long COVID symptoms?
Yeah, so that the study that came out of Northwestern saw that people would get the vaccine, and then they'd have kind of exuberant immune responses, and it is concerning, that some people would have more symptoms from the vaccine afterwards, if they've had long COVID. But it might be a necessary thing, because if there is, a reservoir somewhere, we kind of need to train the immune system. I think there was a recent publication where somebody had chronic COVID. It wasn't going away, and then they got vaccinated, and then it finally subsided. So it could be, I know that the vaccine can be causing some inflammation and causing some symptoms for people, but I think that if the vaccine is able to cause the virus to then, subside or be killed or eradicated from the body, then the inflammation may eventually subside.
Thank you.
I had a quick question.
Yeah.
I just in the chat, I was wondering if you could speak about the potential long-term implications of school reopening policies in the UK, the southern United States, Brazil, other countries where they've just let the virus run rampant What's the latest on long COVID in children and sort of the potential impacts of these reckless policies?
Yeah, so I would imagine, and there's a publication that lists a lowered productive lifespan in kids, and it's longer. It's more of an attenuation in kids than adults. So it's a bad idea. You know, we're setting kids up to have chronic illness.
Could you talk a little bit about the letter that you wrote and maybe more about the neural things that you've been talking about?
Sure. I just compiled a list of research, you know, with all the concerns and focusing on all the neural manifestations of COVID. And I find it very concerning, you know, because it's obviously causing, you know, T cells to infiltrate the brain, neuroinflammation, and encephalitis. So I find that that's kind of one of the most worrisome things about COVID or having long COVID is potentially harming the brain. And it's especially concerning for children. Yeah, if kids are going to be in schools and then catching this and then may have long-term neurological problems. So that's why I compiled the letter. And there's always new science coming out too, and it can be concerning as well. So I try to update it when I can.
Thank you. I think it's had an important influence. Are there other questions? Yes.
Yes, please. Hi, Anthony. Thomas speaking. I would have a question. Namely, I would like to know whether there is data, actual data around, which tells us something about the case in which B cells have disappeared. So both regarding IgA and IgG, I would be interested separately if there is even data which tells us something for both cases. So IgA disappears first for vaccinated people as immunity wanes, so 2 to 3 months, I guess, after a full vaccination, and say 95% of the vaccinated that actually develop them. IgG takes a bit longer to disappear, but so in the case that those antibodies disappear, which I presume that is a natural sort of reaction of the body and cannot be different if you don't re-engage in the sense that you just make them come back by another, say, nasal vaccine in the future, looking ahead or the like. But let's say they're gone. Now the question is there data that tells us in how far adaptive immunity can protect from these mechanisms setting in, from functional depletion taking place in this migration, say the long COVID, neuro COVID, in how far do B memory cells, T memory cells, and more generally cellular immunity protect people from this mechanism kicking in? What's the status of the data on this?
Okay, so everybody is showing off cellular immunity data, but it's not good enough to prevent infection or mild and moderate illness. So just forget that. Really, when people are showing off cellular immunity, you don't. I mean, it's very suboptimal. You should rely on antibodies instead, which, as you say, wane, like the IgG and IgA. Yeah, it's well characterized, the waning, and that is why everybody's boosting now. I mean, that's what all the that's what most, probably 25 to 30% of the studies that come out are concerned about, the IgA or IgG waning, and it's pretty much essential for the boost for that reason, because of that waning, and it's physiological, as you say. But I'll post something about that, or I'll write something about it, because that's a great question, but I can't hold all the information in my head, unfortunately, to tell you.
I have one other question, which is, you know, we continue to hear people talking about immunity as a textbook phenomena. You get infected, you get immunity, your immunity prevents the next infection, and the fact that there is physiological damage due to disease that might actually cause things to be not only worse with respect to their health, but also in principle worse with respect to their ability to combat the next disease, is not being talked about. How can we explain to people that the complexity of infection and its effects including immunity, is not being accounted for in this?
Yeah, that's a great question. And so I'd like to refer to Akiko Iwasaki's and Aaron Ring's work, where they show that you get autoimmunity against the immune system. So basically, it's just a clear message that the coronavirus harms your immune system, and it harms your immunity against other viruses and things as well. There's a small amount of data coming out about that, but I think the autoimmunity to the immune system, which they have already mentioned and published, I think it's great to just remind people of that. You don't want autoimmunity to your immune system.
Can I also ask a follow-up?
Sure.
Because you answered the cellular immunity part, but so my understanding is that B memory cells would make the antibodies would be produced within, say, 3 to 4 days after infection.
That's 3 to 4 days after they're presented with the antigens. I don't think that that's fast enough, especially with Delta now, and it's obviously not fast enough. Ravi Gupta, from Cambridge, says that he also doesn't believe that it's quick enough to respond to Delta now, because Delta is so aggressive, especially in the early stages of infection. So it's not reassuring, and I mean, sure, it may prevent severe disease or maybe help a little bit, to keep you out of the ICU. But a mild or moderate case of COVID-19 is serious, and it is harming your immunity, and it will have long-term effects.
Is there data on this?
Data on the speed of replication, yes. So there's nothing from start to finish, of the whole story. There's no one paper, but there's, just a hodgepodge of different publications, and if you aggregate the story together, you kind of get a picture of what's going on.
Yeah. There is a paper that shows that unlike the earlier variants where you have about 6 days to peak, with Delta you have about 4. Is there a last question someone wants to ask?
I had a quick question, Anthony. I was wondering if you could. One of the themes of the article in The Lancet by the World Health Network was really the need to fight for global elimination. I was wondering if you could speak on that and sort of, given what you reported on long COVID, why we have to adopt this global elimination strategy.
So it would be great to have global elimination, because we won't have the huge risk that long COVID entails, which, what hasn't been ruled out yet are the Lewy bodies that have occurred in rhesus macaques. So if that happens in humans, if we start getting neurodegeneration, down the line, who's going to take care of all those people that are afflicted by it? Because every single monkey got it. Do we really want to risk like almost everybody in the populace, and have a very, very small amount of people that will be kind of competent or able to take care of these other people? I think there's a risk, we might see institutionalized, institutionalized, like end of life, like where, people aren't taken care of. They're just like, given a drug and then they pass away. I can't think of the word right now. But I think we run a big risk of something like that, just a massive amount of people with neurodegeneration and problems. So it would be very wise to have a strategy of elimination at each locale and from each government, and use technology for that. I think we're kind of archaic in what we're doing. And sorry, it's getting dark here because the sun is set.
Okay, so can I comment? Because then I understand that, of course, vaccination doesn't prevent long COVID. This is the message. And we have to be careful not to discourage vaccination, but on the other hand, also highlight the fact that only vaccinating is not going to prevent us from this catastrophe that you were just describing, right?
Yeah, we have to have masks with vaccines.
Okay. Well, thank you very much. I think I'm going to draw this session to a close. Let me let you know that the closing session of the program of the Global Summit to End Pandemics will be taking place in half an hour.